This episode is going to cover an approach to anemia, which is actually an update on the first series of videos I did on the channel. The meaning of anemia is a low level of hemoglobin in the blood, the protein that is primarily responsible for carrying oxygen within the red blood cells. Normal values for this vary between labs, however is generally under 13.5 grams per deciliter in males and 12 grams per deciliter in females. It is a commonly found problem. Some sources quote up to 30% of the world's population are affected by it, and part of this is because anemia can be caused in so many different ways, including potentially being a sign of severe disease such as cancer, and therefore a reliable approach is needed. The main way in which anemia is divided is the mean corpuscular volume, MCV, which is the mean volume of the red blood cells in a given sample, with different causes of anemia having a different effect on the volume. Another important metric to remember is the red cell distribution width, which is a measure of the variation in volume of the red blood cells. A large variation would mean that there are small and large cells in a sample, while a small variation would indicate that the cells are fairly uniform in size. Microcytic anemia means the red blood cells have smaller volume, defined as less than 80 femtoliters. Normocytic is defined as 80 to 100 femtoliters, while macrocytic means a larger red blood cell volume above 100 femtoliters. Within microcytic anemia, we have the most common cause of anemia worldwide, iron deficiency anemia. This is caused either by a chronic low intake or absorption of iron, which can include poor dietary intake of foods like beans or meat, or poor absorption due to conditions such as celiac disease, or even in those who have had a gastrectomy or are using proton pump inhibitors, as these reduce gastric acid secretion and an acidic environment favours absorption of iron. The other major cause of iron deficiency is chronic blood loss, for example, with menstruation being a common cause in younger females, and certain cancers such as colorectal cancer, or even through a peptic ulcer, generally in older people. Diagnosis features looking at iron studies, including ferritin, which is a marker of iron storage, which is low in iron deficiency anemia. Bear in mind, however, that ferritin is an acute phase reactant, and so rises with inflammation, which may mask iron deficiency. Total iron binding capacity is high, and generally this will be the opposite to the ferritin. And in this case, transferrin saturation is low. Remember that iron deficiency is not a diagnosis, and a cause should be found. For example, via fecal immunochemical testing or endoscopy looking for GI cancers, or anti-tissue transglutaminase (TTG) antibodies looking for celiac disease. Treatment is then based on the underlying cause and often features provision of iron either orally or intravenously. Thalassemia is another cause of microcytic anemia. It is a disorder in the genes coding for the globin portion of hemoglobin. Normally, there are 4 alpha genes and 2 beta genes. If the disorder lies in the alpha genes, then it is termed alpha thalassemia, with varying severity depending on how many of the 4 genes are affected, and likewise with beta thalassemia, though we only have 2 genes. Often, thalassemia produces a very low MCV, usually close to or below 70 femtoliters, and the reticulocyte count is typically above 2%. More on those shortly. This is most common in people with Mediterranean or Middle Eastern descent, as it offers a degree of protection against malaria. The Mensa index is the MCV divided by the red blood cell count, and is a useful tool because values above 13 indicate an iron deficiency anemia, while below 13 suggests beta thalassemia. Next, we have anemia of chronic disease or inflammation. This generally begins as a normocytic anemia but progresses to microcytic. It involves having conditions such as malignancies or chronic diseases like renal disease, where there may be a lack of erythropoietin that stimulates red blood cell production, or inflammation like rheumatoid arthritis. In periods of disease or inflammation, there is an increase in liver production of hepcidin, a protein involved in iron metabolism that functions to keep iron locked away, mostly in macrophages, but also prevents iron absorption from the gut. This means that the iron cannot be used by microbes to proliferate, but it is not as readily available to our cells to use either. Ferritin tends to be high, and as such, total iron binding capacity is low, and transferrin saturation is low, as is the serum iron level. Another microcytic anemia is sideroblastic anemia, with sidero meaning iron, representing in this case where we essentially have iron available, but it is not able to be used effectively due to defective protoporphyrin synthesis, which is a molecule that is the precursor to heme, a key component of hemoglobin. This leads to accumulation of iron in the mitochondria, which then surround the nucleus of immature red blood cells, hence the blastic portion of the name, and this is the pathognomonic sign known as ringed sideroblasts. This can be congenital, for example a deficiency of aminolevulinic acid synthetase, or can be acquired, such as in lead poisoning. In these cases, ferritin is high, total iron binding capacity is low, and transferrin saturation levels are high. Next we have normocytic anemia, which as we said has an MCV of 80 to 100 femtoliters. We can broadly divide it into hypoproliferative, meaning a decreased production of red blood cells from bone marrow, or hyperproliferative, meaning an increased number of red blood cells are being produced in response to their destruction or bleeding. And this can be determined by looking at reticulocytes. Reticulocytes are immature red blood cells that normally circulate in the blood around a day before their maturation, making up usually 0.5 to 2% of the circulating red blood cells. But they would increase in anemic adults if the bone marrow is working correctly. It's also worth noting reticulocytes are usually slightly larger than normal red blood cells, so can cause an increase in the MCV if there are enough of them. In hypoproliferative cases, there is less than 2% reticulocytes, but more than 2% in hyperproliferative. Hypoproliferative examples include anemia of chronic disease, as we just mentioned, aplastic anemia, which would feature pancytopenia, meaning low levels of platelets and white blood cells, as well as anemia. This can be caused by parvovirus B19 or drugs, like for example chloramphenicol. Another example is bone marrow infiltration, for example through leukemia, myeloma, or myelofibrosis. As for hyperproliferative causes of normocytic anemia, these can include hemorrhage, as well as hemolytic anemias, meaning breakdown of red blood cells. These are divided into extravascular, meaning the red blood cells are destroyed outside the circulation, commonly in the spleen. Examples include hemoglobinopathies like sickle cell or thalassemia, enzyme pathologies such as G6PD deficiency, membrane defects like hereditary spherocytosis, IgG autoimmune hemolytic anemias, and can be drug-related, for example antibiotics like cephalosporins or penicillins. Intravascular causes feature red blood cells being lysed within the circulation, but this is less common. Examples include IgM autoimmune hemolytic anemia, paroxysmal nocturnal hemoglobinuria, transfusion reactions, and diffuse intravascular coagulopathy. Sickle cell anemia can actually result from both. Hemolytic anemias generally will have an increased reticulocyte count, as well as bilirubin and lactate dehydrogenase as a result of the increased red blood cell breakdown. A mixture of microcytic and macrocytic anemia may produce a normocytic anemia. However, a clue that it is mixed comes from an increase in the red cell distribution width. They would be both small and large cells. Then we have macrocytic anemia, where the MCV is above 100 femtoliters. These can be further divided into megaloblastic and non-megaloblastic. Megaloblastic meaning we have a problem in DNA synthesis, which is suggested by features such as hypersegmented neutrophils on peripheral smear and presence of megaloblasts, which are immature precursor red blood cells. Megaloblastic causes include vitamin B12 and folate deficiency, with vitamin B12 deficiency often being seen due to pernicious anemia, where antibodies are produced against parietal cells in the stomach or intrinsic factor that they produce. Other causes include malabsorption syndromes like pancreatic insufficiency, Whipple's disease, or small bowel bacterial overgrowth. And since it is mostly absorbed in the ileum, Crohn's disease can also be linked to it. Folate deficiency mostly comes from a diet deficient in fruit and vegetables, but can also be caused by celiacs and Crohn's. The important difference between the two are that it takes a long time to become deficient in B12, but folate stores can run out in just a few weeks. Non-megaloblastic macrocytic anemia results from causes other than issues with DNA synthesis. For example, chronic alcohol use, which itself can lead to B12 and folate deficiency, liver disease, hypothyroidism, myelodysplastic syndromes, and sometimes hemolysis and hemorrhage, which may lead to high levels of reticulocytes. Often, anemia can be asymptomatic and found on incidental testing, and generally, healthy adults can tolerate a significant anemia before becoming symptomatic. General symptoms and signs that could point to it include fatigue and weakness, dyspnea, meaning shortness of breath, especially on exertion, headaches, dizziness or lightheadedness, palpitations, or pallor, for example generalized or conjunctival. In severe cases, symptoms can include signs of hemodynamic instability, such as hypotension, heart failure, chest pain, or syncope. Some features suggest a more specific anemia, like iron deficiency may have pica, where patients crave chewing strange things like ice cubes and dirt, and other symptoms can include glossitis, koilonychia, meaning spoon-shaped nails, and angular chelosis, meaning cracking sores at the corners of the mouth. Hemolytic anemia can often have jaundice and dark urine as a result of the increased serum bilirubin, and vitamin B12 or folate deficiency can also cause neurological manifestations such as numbness, tingling, or even changes in mental status or mood that may mimic dementia. Treatment is largely dependent on the clinical presentation and the underlying cause. In those who are unstable, symptomatic, or have extremely low hemoglobin counts, with cutoffs typically being around 7 to 8 grams per deciliter, then transfusion is an option. In most instances, however, treatment is directed towards the underlying cause, for example identifying and stopping a bleeding causing iron deficiency, while supplementing iron either orally or via an infusion. Ensuring adequate oral intake in those with nutritional deficiencies, or even B12 injections intramuscularly in those with pernicious anemia.